who have joined from outside the state as well as from the state, and my beloved friends. Good evening and greetings. It's quite exciting to have you all around for another interesting round of our monsoon vibes. This could be definitely a round where we have got an excellent topic at hand and a cream faculty or a vibrant, enthusiastic faculty in place. Friends, as you all will agree, pediatric infectious diseases have always been a fascination for us. Apart from allergic disorders as well as respiratory, it is our bread and butter in the practice. And we would never miss an opportunity to learn from our infectious diseases. Any number of information, seminars, webinars are always welcome. And still we tend to miss what you say, some loopholes or something else could have been done in this scenario. Even yesterday we had a great session from Dr. Vijay Avale where he had the utility and limitations of lab tests. We learned quite a lot, something new. So I believe every session on infectious diseases, especially have something good to offer, something in our practice, something very useful in our clinical practice. And that's where the charm of infectious diseases practice lies. And for the session here today, we have got a cream faculty, and let me take the privilege of introducing them to the slides. It's a proud privilege to introduce Dr. Abhay. He is the chief faculty, also the moderator for the day. And Dr. Abhay is always a smiling face, as you could make out. He has been the president of the ED chapter for 2015. He has been an executive board member of Indian Academy of Pediatrics 3 or 4 times. And he is a member of the ACVIP committee, the immunization committee, and he has been an academic editor for quite a good number of books. Hailing from Ahmedabad, he has been at the helm of academic in Indian Academy of Pediatrics over the years. And even today he had a session in Central Zone Pediatrics, as I have learned right now. So I'm sure Sir is there to take the team forward. And we are so privileged to have the current president of the infectious disease chapter, Dr. Yagnesh Popat in Rajkot. And he is the national vice president of the IAP ID chapter previous years, IAP executive board member for 2 years. And he's all in all for apart with the Rajkot IAP, apart from Dr. Ranjesh as well as Dr. Yogesh Parikh. And it's a couple pediatric family. Dr. Sati Popat is also there, very active, and they have been good friends for me in the IAP, especially in the IAP evening get-togethers, both of them. Welcome, Dr. Yagnesh. And our doyen from Hyderabad is there, excellent speaker, Dr. Ranganath Daruru, professor of pediatrics from till 2014 at Usmania Medical College, and currently medical superintendent Nilofer Hospital, the famous institute in Hyderabad. Presently, professor and HOD, Mallareddy Medical College, Hyderabad, and he's been favorite domains have been critical care and infectious diseases. Welcome, Dr. Ranganath Daruru, sir, to our midst and for this evening. Dr. Rajendra Khadke, I've learned of sir through Dr. Ganesh Kulkarni only, and he has been a vibrant practitioner with a lot of work, especially in immunization. He has been in critical care as well as immunization has been its major areas of interest. And that module from IAP Aurangabad on immunization book he has been the course coordinator, and that is a wonderful book which you will never tend to miss once you have it in your place. I still carry this in my office as well as one copy in my desk home also. And he is the national faculty for immunization, and he has been there in many organizing forums and as the president of IAP Aurangabad. And sir is here to enrich us on his experiences as well as thoughts on infectious diseases with the other cream faculty. Welcome, Dr. Rajendra Khadke, sir. And we have got another vibrant lady, ma'am, with us. I've been very, very enthusiastic. Dr. KHEYA GHOSH from Calcutta. And KHEYA is known in all the infectious disease circles as an excellent speaker, very actively involved in the infectious disease activities as well as in IAP activities. She is Secretary of IAP Infectious Disease Chapter right now, and she is an Associate Professor and NAC in charge of one of the largest hospitals in Asia, the Institute of Child Health, Calcutta, which caters to quite a large volume of pediatric patients. We are quite happy to have you with us, and welcome Dr. KHEYA. So friends, we have got an elite panel here today to take up some interesting cases, the pearls, I believe. Dr. Abhay would like to prefer, and the team would like to probably call it as pearls. So we definitely have some pearls or diamonds to take home from this session today. And going by the discussion in the group, that short group which has been created a week back, it could be an amazing session here today. And please be free enough to post your queries in the chat box, which will be taken up at the end of the session. And I could see a lot of our infectious stalwarts, especially Dr. Venkateswaran from the president of IAP Tamil Nadu infectious disease branch is also here, and Dr. Anthony Nasrat and so many of seniors from other states are also around. So welcome all my dear friends, and let's start moving to the scientific session. Over to Dr. Abhay Shah and colleagues to take over, please.
I want to share the slide. Can someone allow me?
Yes, sir. It is open, sir, I believe. Nobody has taken control. You can take away. Take over.
1 minute. 1 minute.
Sir, your screen is already visible. It just shows a zoom. Just minimize the screen and start the slides.
Is okay?
Yes, sir.
Yeah.
So put it in slideshow.
Where is the button? Yes, now coming. Yeah, okay. So thank you, Dr. Ramesh Kumar, for nice words of introduction. Thank you, IAP Kerala, Office Bearers, Dr. Narayana, Dr. Balachandran, all my friends on this digital platform for giving me this wonderful opportunity. Even in the unprecedented time of Corona pandemic, it is nice to have this type of the webinars, and it is a very, very good gesture on the part of Dr. Ramesh Kumar and IAP Kerala Kochi for this wonderful opportunity given to me along with my panelists. All the panelists have already been introduced, but the real introduction will become when they take part in the scientific deliberation. With this, let us first go with the scope of presentation. So it is going to be a case-based discussion. And mind you, these are going to be a very, very common issues. The gems, pearls, and diamonds are not freely available. They are very costly also. But here, and they are very uncommon for so many of the person in their day-to-day life. But these are common issues. And from these common issues, we need to dig the mountain and search for the pearl. So with the help of this expert, I'm sure we're going to have a wonderful take-home message for each of the case. And the basic aim of this will be a rational institutional practice and a rational management practice. And it will be a case-based discussion. You need to think that as you are sitting in an emergency room, you are sitting in the OPD, and what would exactly offer to the parent and to the child. That will be the motto of this case discussion. With this, I start with the first case. It will be in rotation, one by one. The questions have not been earmarked to anybody. So all the panelists are requested to respond one by one. First will be Dr. Yagnesh, followed by Dr. Daruru, then Dr. Khadke, and then Dr. KHEYA. So here is a 7-month-old male child who has been immunized as per the government schedule, comes with the history of fever, 101 degree. There was severe throat pain. There was a child was not able to swallow that comfortably of 1 day duration. So it's an acute illness. And if you look at the throat examination, there are multiple vesicles with a erythematous base on the palate as well as the tonsil. However, there was no exudate on the tonsil. The similar illness were there in the elder brethren 3 days back, and there was no anterior cervical lymph node. So this is the child. With this background, what could we have thought? Which are the likely bugs would you consider in this case, Dr. Yagnesh?
Yeah, can we go back to previous slide, sir? Yeah. So, friends, we have a 7-year-old child with a fever, which is high grade, associated with coryza, multiple erythematic vesicles with erythematous base on palate. So, we are dealing with a case of an tonsil pharyngitis here. And there is similar illness in the family, no tender lymph nodes. And so the probable bug here would be a viral infection. So probably finally coming to the conclusion, we are dealing with a case of an pharyngotonsillitis, probably of a viral origin. And the virus,
Can you specify a virus with this type of picture?
Yeah. Viruses which are common here could be either EBV virus with RSV virus, adenovirus, Coxsackie virus, or even coronavirus should be considered. Of course, coronavirus will not show such erythematous vesicles and other things, but the viruses are the common bugs here. Almost 40% of the cases.
Yeah. So, Dr. Rajendra Khadke, Dr. Ernest has told that it's a viral infection. So, in terms of this vesicle erythematous base, would you like to narrow down some diagnostic possibility as which viruses will cause this type of picture? Hello.
Unmute, sir.
This clinical scenario fits into a herpes simplex virus, probably, and that will be a first things to be considered.
Yes, sir.
Secondly, we can have such type of lesions in hand foot mouth disease also. But
Yes,
the difference between the hand foot mouth disease and this disease is basically those lesions are posteriorly placed in buccal mucosa, while these lesions are placed anteriorly in the mucosa. So these are the two differences which can really say that probably we are dealing with the herpes. So Coxsackie and herpes should be at the top priority rather than other illnesses.
Yeah, so presence of vesicles and erythema is very, very highly suggestive of viral, number one. There is no exudate. There is no exudate which rules out the bacterial infection, and similar history in the elder brother means the same viral is going on. So typical viral picture, and looking at the morphology of the lesion, we have the vesicle lesions, and it is very, very classical as the herpes. But in herpes, the anterior part are affected. Here, the deeper parts are affected. So we are more dealing with a case of herp angina. So this is a classical picture which suggests that bacterial and viral infection. Out of this, if there is absence of cough, if the tonsillar exudate is absent, if there is history of fever, if there is anterior cervical lymph adenopathy is there, and age is between 4 to 15 years, probably it says that probably it will have a positive predictive value having a bacterial infection in the tune of 40 to 60%. As against that, if there is erythema is there, vesicles are there, they are highly suggestive of a viral infection. So dealing with a viral infection, looking at the pain, that is odinophilia, difficulty in the swallowing, erythematous base, and the ulcer, so the most likely that clinically we are looking at a case of herp angina. So Dr. Daruru, would you go for any investigation in this case?
In this, the cases can be, as we have to give an evidence for the disease. So we can have a throat swab, we can have a CBP, we can have throat swab culture. But routinely we do not do, because we know that it is a simple herpes with our herpangina with our experience. But if really you want to investigate, there should be a membrane or a follicular tonsillitis or involvement of the anterior pillar of the palate, anterior pillar of the tonsillar fossa should be involved. Here that nothing of that sort is there, and there is a family history, so it should be a viral only. So it may not require, but this may throw some light on the causative organism.
Yeah, so point is well taken that the diagnosis is very, very clear on clinical ground. In most of the more than 90% of cases of tonsilopharyngitis, may be it a bacterial, may be it a viral diagnostic modality, that is Its laboratory workup is not required. Diagnosis is only clinical. Even a CBC is not going to help because polymorphonuclear predominance may be there in the early part of viral infection. The only indication, whereas Dr. rightly said, that if you are suspecting a diphtheria where there is a membrane, then a throat swab is very, very important. That is important. Now, in this child, somehow someone has done a throat swab and is positive for a group A beta-lactic streptococcus. So, Dr. Kheya, what would you like to do in this case? Dr. Kheya?
So yes, yes, sir. So as you can see, this clinical picture with the vesicular lesions with the erythematous base, and along with there was coryza, typically of viral, and already we have discussed the most probable causes of the virus in this case. So here, first, throat swab should not have been performed, and if it has been performed and we get a positive for gas, we should take with a salt of pinch, because you know the gas is present as a commensal in the throat in 5 to 20% of the children. So we have to see whether it's true gas or not. Most likely it is a false positive and it's just a commensal. So it is not indicating an acute infection, but a commensal. So but of course, we have to see for other things, whether any complications, how the baby is behaving with time. So all those things will help us to pinpoint whether it's a viral or a group A streptococcus. So in that case, we can go for RDT also to just to see.
So here the picture is very clear. There was no need to go for the throat swab, and even if the throat swab is positive for the gas, it is a commensal and it does not a true infection. So we should not give any attention which the child does not require any antibiotic, and what the child requires only a symptomatic treatment. So which cases require investigation? Dr. Daru has already said. So if there is a suspected diphtheria, if there is a past history of rheumatic fever, if there is a URTI with systemic manifestation, if the child is immunocompromised, or if there is an URTI with upper respiratory airway obstruction, these are the situations of the tonsillopharyngitis cases which require investigation. Otherwise, investigations are not required. The diagnosis is only clinical, and if it is a viral, the treatment is going to be symptomatic. So, Dr. Rajendra, how will you follow this case? Would you go for this CBC, or you have some thoughts in your mind?
Sir, this child, the clinical picture is very clear of viral origin, so probably will not do any investigation at this juncture. But if at all these investigations are done like CBC, CRP, this CBC would be absolutely normal, or may show some lymphocytosis. And the CRP
I got a point. So this child requires no investigation. So there is no question of follow-up. No.
Yes,
so Dr. Kheya, now there are a lot of things that are going about the rapid antigen test as a point of care test. How sensitive and specific they are?
So this RDT for gas, this is a point of care test. First of all, I should say whether we should do it or not. As we have already discussed, if the clinical symptoms or the modified center score, that is a MAC-ISA score, if we see the value is more than 3 to 4, or sometimes 2, and with a strong suspicion, we should go for either a throat culture or a RDT. Now, all of you know throat culture will take time. RDT is the point of care test. You can do it in your OPD. It takes only minutes. And you can, in that case, if you get a positive report, the specificity of this test is very, very high. It is to the tune of 95 to 98%. That means if it is positive, there is a high chance that it is truly a gas pharyngitis infection, and you should give antibiotic. Whereas the sensitivity is a little low. So if it is negative, it does not rule out that gas pharyngitis. So if it is negative, and if you think it's a strong suspicion of a gas pharyngitis, you should go for throat culture. But in a recent study by Dr. Bala, I think most of you know this, it has shown to have a very good sensitivity also to the tune of 88%. And only 2 cases who were negative for RDT were positive for throat culture. So we should promote this RDT as a point of care test.
So this is a very, very important message, because there are certain cases where clear-cut viral picture may not be there, clear-cut bacterial picture may not be there. See, bugs and children are not going to behave like a textbook which is written in the book. So So in some subset of cases, probably where the third culture is not visible because of the long turnaround time. And in that case, RDT should be offered, because if it is positive and your clinical suspicion is that probably, yes, I am going to bacterial, even by day 3 or 4, you are going to start the antibiotic. This will help to eradicate the organism and thereby to prevent the complication of post-streptococcal rheumatic fever. So this is a very, very useful tool as far as the point of care test is concerned.
Okay.
So the child has recovered only with the symptomatic without the antibiotics. So message is that it's a pure viral infection. Number 1, diagnosis is clinical. Number 2, what is required? Only the symptomatic treatment, reassurance, and good quality time for the parents. Number 4 is a close follow-up is very important. So CBC CRP has a negative predictive value. It will not confirm either bacterial or viral. Throat swab can detect carrier as well as infection. It is 90 to 95% sensitive, and RDT always issue of availability and affordability, but sensitive is 70 to 90%. But when present, when called off kilogram, it has a specificity in the tune of 98%. So that is about the case 1. Now we quickly move on to yes. Before we start that, we should not miss this, and therefore a thorough clinical examination is important. You should not just focus on the throat. You just not a thorough ENT examination. Thorough examination from hair to heel is because if just in infectious mononucleosis also we have got this exudate tonsillitis, but in that case you will have a lymphadenopathy, you have the hepatosplenomegaly, you will have a rash, especially after amoxicillin. So a thorough clinical examination is important. So any bacterial infection does not be any throat infection which looks like a bacterial infection but does not behave like a bacterial infection, your antenna should be up. A thorough clinical exam is required, and you must rule out condition like infectious mononucleosis. And you can see a beautiful patch here. It's a membrane. It's a pseudo membrane. It will bleed when you try to scratch it or remove it, and there will be a bull neck. That is because of this is a case of diphtheria, and should not miss this. Once you miss the diagnosis, probably it's a question of life and death of the child. Yes. So that is very, very important as far as this tonsillopharyngeal. So another case too, a 6-year-old female coming from the slum has a fever of 5 days. Fever was very high, 100 to 103. There was no shivering, and there was partial response to paracetamol. In spite of giving paracetamol, child was not that comfortable. There was occasional vomiting. Appetite has gone down since last 2 days, and was treated by family physician for 3 days with some injection, but the details of that medication is not available. And from the child looks ill, little dehydrated. He was febrile, liver 2 centimeter. There was no jaundice. Rest of the examination is totally normal. So, Dr. Daruru, can you give 3 or 4 important differential diagnoses when patient comes to you without examining the patient?
So there is a clue for that it is a systemic infection that is there. Yeah. Because the child is ill looking.
Yes, sir.
And there is liver enlargement. Yeah. Plus the appetite has lost. In spite of some paracetamol, the child fever did not come down, and it has lasted more than 5 days. So we should think about a first, because fever period was not normal, child continued to be ill looking, a possibility of malaria, a possibility is she's a female, a urinary tract infection, a possibility of malaria, and a possibility of enteric fever or any viral fever should be entertained, and investigation should be done immediately.
Yeah. So, Dr. Yagnesh, there are 5 or 6 possibilities has been given. Yeah. From the history, what do you say? It's a bacterial or viral?
This is most likely to be a bacterial infection because child is already ill looking.
Yeah.
But sometimes it does happen in viral infection, which is extended period. But here almost 5 days has already gone, and the child is ill looking. There are systemic signs of prostrations, poor appetite, and others. So probably this is a bacterial infection. One should not miss it. Yeah. One should definitely not miss the fever without focus here. For example, bacteremia. This could be a just simple case of a bacteremia. So one should keep in mind that apart from the other causes that Dr. Daruri has already enumerated.
Yeah. So here we have got a febrile child.
Sir, can I add one?
1 minute. Yes, sir. I'm coming to that. So here we have got a febrile child. Yeah, it seems to be a bacterial infection, but the focus is not. So probably we may be dealing with a bacterial disease, or probably this bacterial disease might localize at a given date. Yes, Dr. Rajendra. Yeah.
Sir, here I just wanted to say that fever for 5 days. So this 5 days was given by you. So it has all differential diagnosis in our mind.
Yeah.
Suppose this would have been 6 day or 7 days fever, it would have been very easy to differentiate.
No, that's true. But what I am giving about the history is available with me.
So now when we have a 5 days history, we have all illnesses which are in mind. So whenever we are thinking about it, can be a viral like dengue, or it can be a bacterial infection like entry. So what is most important is basically interfebrile wellness of the child.
Yeah, that has been told by Dr. Daruru.
So that is also very important, sir.
Now,
and associated symptoms
any new comment, please.
Associated headache, intense headache, retroorbital pain, macular rash, or all these things would point to dengue at this moment.
But yeah, they are not there in this case.
They are not there.
Okay. So here it seems that probably the child is having some form of bacterial infection. It may be a bacterial disease, or this bacteria might localize and give a clue in the later. Let us see how the case progress. Now, Dr. Yagnesh or Dr. Kheya, how will you approach to a case? Would you admit, or what would you do with this case?
So this baby, as you said, can I get the first slide, the previous slide? So the baby was had vomiting with a poor appetite, and the very important point, as you have marked in red, is a ill-looking. So ill-looking child with an hepatomegaly, which marks that there is systemic infection. We have to search for the red signs, some of the red signs, whether the baby is having any dehydration, going to shock, what is the blood pressure like, what is the saturation, and we should admit to find out whether there is any red signs, and we should admit this case because this baby might need an extensive investigation. Yeah. So it's most likely it can be a bacteremia which can go into shock. So I should admit and maintain the hydration because the baby is vomiting. So we should go for hydration, stabilize the baby, send the blood investigations, especially blood culture in this case, and then start our antibiotics if we want.
Yeah. So this child was admitted, rightly so. And so on a Dr. Daruru, how will you initiate this child on a day 1 of the fever? Means day one of the fever. Day one, not day 1 of the fever. Both day 1 of the fever as well as on the 5th day when the child comes to your OPD. How will you manage this case?
On the day it's my OP, I think just follow up. But if she has come on 5th day, definitely I would like to admit her and stabilize, then investigate. The investigations include CBP to rule out malaria, and blood culture will be sent, and CBP may give some of the hints, clues or points to say that it is a malaria has been ruled out through that one. Plus we will look for the platelet counts, we will look for the abnormal lymphocytes or any abnormal cells which can give us a clue for the diagnosis.
Yeah, so point well taken that first CBC when done on the day 1 of the fever is usually not required. But here the child is come on day 5. Not only the child is ill looking, therefore we will definitely go for the investigation upfront. So, however, the CBC will have a more of the negative predictive value. And secondly, it gives a baseline value. And this is very, very important in a case of dengue or a rickettsia where the serial fall in the platelet is very, very low. So it will give a baseline value. Sometimes it gives an idea about a diagnosis. We may confirm malaria. If you pick up a malaria parasite microscopy, it gives a statewide diagnosis. Sometimes it's a chronic illness or acute on chronic illness, a presence of abnormal cell may be found, and probably we may think the child may have some serious disorders like leukemia. So if in the first CBC itself, if there is extremes of the count, I mean WBC less than 5,000,
yes,
or WBC more than 15,000, 20,000, probably we are dealing more with a bacterial infection. That is very, very classical of bacterial infection. Similarly, absolute neutrophil count will give. So remember, when more than 2 cells are affected, it is also a catch, and you have to be very, very careful. So it will give a baseline value. Most of the time, it may give some pick up the diagnosis like malaria, or sometimes extremes of the count will help us to rule out bacterial infection, at least not to confirm the bacterial infection. So about this. So Dr. Rajendra, what about SGPD in this case? Would you go for the SGPD?
Sir, considering the story of this child, probably SGPT would not help in diagnosing something, but at the same time, it would be marginally raised in viral as well as bacterial infections, which will be in hundreds, but it will never be in thousands.
Yeah. So now
Sir,
this
sir,
Dr.
sir,
Dr.
yes,
KR, here the
sir,
child was in 1 minute.
no,
Child was
regarding SGPT, I would like to add, because SGPT, whenever you are getting a hepatomegaly, you should do it, because there
exactly.
are bacterial infections involving liver. There are viral infections which involves liver, like dengue. So in that case, an SGOT, if you have to do one test, SGOT or SGPT, you should do for SGPT, because SGPT is more specific. SGOT is an enzyme which is liberated from many other organs like muscles, kidney, heart. So SGOT may be falsely raised in other conditions, whereas SGPT is more specific for liver. So to see liver involvement, we should do it.
So the point is that the message that we drive home here, that probably in all the febrile cases, SGPT is not required. But particularly in this case, child was febrile, liver was palpable, child was having vomiting. So there are all the chances that we may have some hepatic involvement, and SGPT is required. Yes, Dr. Yagnesh.
Yeah, SGPT per se will not give you a diagnosis, but it will definitely say that there is multi-system involvement or not. That will be definitely explained by this.
Yeah. So in that case, there was some leukopenia was there, thrombocytopenia little was there, MP on 2 occasions was negative, malaria was negative, SGPT was slightly raised, but definitely more than 4 times the normal value. Urine was not there, NS1 is negative, and blood culture is awaited. So Dr. Daruru, how will you rate this report?
No,
what is the significance of leukopenia, thrombocytopenia on day 5, high SGPT and NS1 negative?
Sir, there is some sort of hepatitis going on. There is a reduction in the total count, and the platelet count is also coming lower level. So we should always think a systemic infection. It's not malaria. It's not something else. Dengue has been ruled out. So we should think about enteric fever could be a possibility, and we should start treating that one, sir.
Yeah. So here the blood culture was sent, and child is toxic, and we have started with the antibiotic because the blood culture was taken. So Dr. KHEYA, does NS1 rule out dengue?
This is the case where a borderline death, they came at 5th day. So as we all know, the first 3 to 4.
Yeah, yes.
So if NS1 is negative on day 5, we cannot rule out dengue, because had it been on 3rd day, we could have said. So first 3 to 4 days, it is more or less NS1, and NS1 becomes negative from day 5. So on 5th day, if it is NS1 is negative, we cannot say whether it's a negative for dengue or not.
As you know, that's a non-structural protein and is a very good specificity. But actually, this is the test to be meant for day 1, 2, and 3. After 4 days, antibody starts developing, and once the antibody develops, they will neutralize this NS1 antigen. So by day 5, even if it is dengue, probably it may be negative. But even in the first 1, 2, 3, or 4 days, NS1 can become negative, especially when you're dealing with a secondary dengue. So the sensitivity for the primary dengue in a NS1 is really more than 90%. But as well as sensitivity is nearly 65 to 70%. There are all the chances that in 10 to 35% of cases, a negative NS1 can be there. Even if it's done early, it will still we can have a dengue fever. So that is about the role of NS1. Now, as far as the SGPT is concerned, Dr. Rajendra has already told that you have to look that if the clinical icter is absent, but SGPT is in hundreds, probably you are dealing with a case which is other than viral hepatitis. So it can be an enteric hepatitis, Dr. KHEYA was telling, Dr. Darul was telling, it can be malarial hepatopathy, it can be a liver abscess if clinical correlation is there, but in case of viral hepatitis, fever is not going to be high grade, but SGPT should be in 1000, at least more than 500. In other cases, fever will be high, but SGPT will be mild to moderate. So that is how the SGPT will be useful in a fever of short duration. And as far as the blood count is concerned, early leukopenia, neutropenia is common with dengue. Rising hematocrit, low platelet is common with dengue. Extremes of the count, I already told, a bacterial sepsis, leukopenia with no or low eosinophil, and thrombocytopenia occurring after 5 days of the illness is very classical of enteric fever. Anemia with eosinophil is malaria, and monocytosis is common with malaria and enteric. But of late, this classical picture is not found. Now we have number of studies found. There were clinico-pathological and clinico-bacteriological investigation correlated, and now the leukopenia eosinopenia, they have all been found in a less number of cases as far as enteric fever is concerned. So now we have to rephrase our textbook as far as the WBC and eosinophil concern. As far as enteric fever is concerned, rest is very, very classical still in majority of the cases. So that is about the CBC in a short febrile illness. Now, what about blood culture, Dr. Rajendra?
Sir, the blood culture, in this case, basically, when we are thinking about a fever of 5 days origin and with a toxic child, we are supposed to send a blood culture prior to giving any shot of antibiotic.
Yes, sir.
So the blood culture is must in this case, and we should send 2 sets of culture in
Yes,
this,
sir.
and that culture has to be sent as early as possible to the laboratory. It should not be refrigerated. If there is a delay, you can keep it in the room temperature, but you should not delay. And there has to be 1:5 dilution for this blood culture. At the same time, we should try to get at least 1% of the blood volume. So in this child who is 15-16 kg weight, probably will have to have 10 to 15 ml of blood drawn for the investigation. And then this blood culture has to be sent, sir. And you can send it for you can send it for backtake, so that probably early reports can be achieved in this.
So most of the laboratories now doing a backtake test. A turnaround time is nearly 2 to 3 days. It is very cost effective, and in addition, it will give us a idea about the drug sensitivity, and salmonella are easy to go. So it's the advantage of, and blood culture is a gold standard. As far as enteric fever is concerned, blood culture is a gold standard. And how to increase the yield, Dr. Rajendra has already said it is 1:5 is the ratio to blood to broth. So a good quantity of the blood, and this ratio is also important. It is not that you take 8 ml of blood and there is only 12 ml of the broth. It is not required. So 1:5 ratio has to be maintained as far as blood and broth is concerned, and that will give a good yield of the blood culture. Now, Dr. Yagnesh, you have got a culture and center report. What will look in the blood culture report?
First of all, what bug we have found out, that is to be seen. Whether it is a common organism or whether it is what is a pathological organism, that one should definitely look into. In the sensitivity pattern, sensitivity to routine drugs, or it is a resistant bug, that is also to be looked at. So these couple of points one should look into the any blood culture report.
So when you, apart from this, when you isolate any bug, it is very important to find out whether this bug is really a cause of infection for a given site or not. That is very, very important. Suppose if you do a throat swab culture, and you find MRSA, so staph is not going to pathologic. It said it is commensal. So similarly, here also in blood also, there are a number of commensal there, contaminants are there. They have to rule out and you treat for the real true infection. Number one. And second, now we have to look. You have to look at the MIC. You should not look at the zone diameter, because zone diameter gives an erroneous report. So MIC is very important. And depending on the MIC, you have got S that is sensitive, I that is intermediate sensitive, and R that is resistant. So you have to follow the MIS as per the CLSI guideline criteria. So it is about blood culture. And in this case, we isolated the Salmonella typhi, which was sensitive to ceftriaxone. So in this case, ceftriaxone started, and we in a perfect dose. Child was still febrile on day 5, but otherwise doing well. So here the child continues to have fever, but is well. So would you change antibiotic? Would you add antibiotic? Anyone can take this.
No.
Same medication. There is no need to change or add any further antibiotic. Because
sir, I will wait for another 2 days for the response.
1 minute, one by one, either raise the finger or let one finish and then second. Yes, Dr. Yagnesh.
I will still continue with the same antibiotic. There is no need to change, because enteric fever may take time to resolve it. Child is otherwise doing well, comfortable. So wait for another at least 2 to 3 days before changing or adding any antibiotic. And usually, if at all required, we should not add any antibiotic. We should change antibiotic.
But yes, Dr. Darul, what you want to add?
Nothing, sir. Because the time taken for the bacteria to be responsive, the antibiotic to show its effect, it may take a little bit longer time. But the clinical feeling that has to be taken into decision. Here, the child was well. So I would like to wait for another 2 days for her to improve and the drug to act. That's what I wanted to say.
So the average clinical response will take place by 4 to 5 days. Sometime it may be extended 7 or 8 days also. But the child is not toxic, taking well orally, heart rate is coming down, and otherwise looking well. Means comprehensively child is doing well. only fever is the problem, then probably you continue the same treatment. What is required that you have to reassure the parents well. But there are some situations probably where even after 7 day or 8 day, in spite of giving the perfect drug as per the culture, perfect dose, you have ruled out the complications like thrombophlebitis, UTI associated with, still the child has got continuous sort of fever. And this is a real delayed deprivations, which call it as a clinical failure or the therapeutic failure. In this case, very small case, it will not appear. Here, there, you have to change the antibiotic. You cannot add. So there is no scope of the 2 antibiotic. You have to change the antibiotic. And here either you can go for the azithromycin or you can select any of the sensitive drug which is useful for typhoid, like amoxicillin, cotrimoxazole, or even ofloxacin can be given. So message here is that only a single antibiotic as far as the drug is concerned. So as far as the response is concerned, if there is deprivations within first 24 to 48 hours, most of the time you are not dealing with a typhoid fever. You have to review the diagnosis. The diagnosis is wrong. Number 2, usual time for the response is 5 to 6 days, but fever may persist till second week. In that case, you have to rule out all the complications, including HLH or this phlebitis, all that. And comprehensive improvement is very, very important as far as the typhoid is concerned. Yes, Dr. K, I want to add something.
No, sir, you have already covered that. I
Okay.
just wanted to say that typhoid in our country is quite sensitive to ceftriaxone. Yeah. So don't add on azithromycin. It's a clear cut, a single drug. And the question of this MDR, XDR, it's not that much existent in our country. That's
yeah. I want to clarify to you. We are having a MDR typhoid. What is MDR? Which are resistant to ampicillin, cotrimoxazole, amoxicillin, chlorpheniramine. But what is XDR? They are not responding third generation cephalosporin, and only required for that is a azithromycin and meropenem. So here we are in the stage of MDR, but Pakistan and other countries have gone to XDR level as well, and therefore it is very important to salvage azithromycin. So as far as the take-home message is concerned, if child is not improving, we have to rule out the complication, and it may be a complication of phlebitis, UTI, that is co-infection. It may be a big serious complication like HLH, or it can be an immune-mediated fever. In most of the immune-mediated fever, child will be pretty well, and then there is a reoccurrence of the fever. Yes, Dr. Daruru.
Sir, with the experience what I have in the infectious department of Hyderabad, if the child is not, if the tests are not showing you anywhere, so please do a blood culture and submit it. Even the treatment, after treatment also, the blood culture will be positive. You are lucky that you got a patient who did not have anything, but in a common setting, you should have received some drugs and they come to the hospital. Then if you are thinking that still it is entering, please do a bone marrow culture and that will be 100% sensitive and it will give you the result before entertaining other diagnoses.
I think, what about other panelists? Bone marrow culture in typhoid?
It is not routinely required, sir.
Yeah, exactly. So if we are doing a workup for the PUO,
then
in that case, a bone marrow is done. In that case, a bone marrow should be sent to the culture and look for the typhoid and brucella. But otherwise, for a suspected case of typhoid, I think if blood culture is negative, one should not go for the bone marrow culture. It's a very invasive procedure. Okay.
If partially treated outside, which is not showing any culture positive, then it has to be subjected, sir.
Sir, Dr. Daruru, as you were mentioning, if someone has received an antibiotic, there will be less chance of getting that.
Yes. Not this
from
case,
outside, there will be less chance in getting the blood, because in bone marrow, you have a very high percentage of bacteria in contrast to the blood. But bone marrow is such an invasive way. We don't usually, practically, we don't do a bone.
The situation is so.
We will not discuss internally. I will give a final verdict. Please bear with me. So bone marrow yield is very good. It is more than 50 times compared to blood culture, but it is not a standard of care to be provided in all the cases. It is only as a part of PUO workup, where one of the possibilities can be typhoid, where repeated blood cultures are negative. In that case, always ask the laboratory to do a blood culture simultaneously along with the routine bone marrow examination. So as far as the message of typhoid fever is concerned, do not use more than a single antibiotic. Do not use BL-BLI combination like ceftriaxone tazobactam, because these organisms are not producing beta-lactamase enzyme. Sometimes in 100% of cases, our salmonella are going to be sensitive in vitro to aminoglycoside. But these salmonella are the intracellular organism where your aminoglycoside is not going to work. So do not add aminoglycoside, just showing the culture report. Do not use fixed dose combination with 2 antibiotics. and do not use a combination with FDC with probiotics. So that is about the case number 2. Case 3, KHEYA 3-year-old child, fever of 4 days. There was one episode of vomiting previous night. Child was otherwise playful. Examination was normal. There was a total count 50,000. CRP was somewhat raised. MP negative. Urine routine macrosource 20 to 20 per cell. Culture was done, which was E. coli 1 lakh. Started on cefixime and responded well. So it's a clear-cut case of UTI. Culture proven UTI. Responded well, but returns after 4 days with high-grade fever, now vomiting 7 to 8 times, looks ill, there is some dehydration, clinical rest of the exam is normal. What it can be? Dr. Rajendra Bhai, can you take this?
Sir, this child is coming, the first diagnosis of urinary tract infection is well taken because the culture positive as well as 1 lakh count are there on culture.
Yeah.
Now this child has come with the second episode of urinary tract infection. So we call it as a recurrent urinary tract infection because it has come in first 6 months of first episode.
Yeah.
Now, when we think about recurrent urinary tract infection, we have a number of things to look at it and do some special investigations apart from treating this child.
Yeah.
So we will have to do a urine.
One minute. I will like to interrupt. So here's a case of recurrent. Which are the factors for this recurrent UTI? Can you tell me?
Sir, there can be an anatomical problems, congenital abnormalities, and commonest in female is vesicoureteral reflux. There can be an abnormal urethral opening. There can be an ureteral opening, which can be at vulvas also. So many congenital abnormalities can cause a recurrent urinary tract infection. Neurological problems like neurogenic bladder can cause urinary tract infection. And the third most important is constipation or bowel bladder abnormalities or functional bowel bladder abnormalities can give rise to urinary tract infection.
Yeah, so you enumerate all the causes. The most important, commonest cause of recurrent UTI is the improperly managed first UTI. This is the commonest cause. And second common cause will be associated constipation and phimosis. And amongst them, in 30% of cases, the proper investigation has not been as far as the first UTI is concerned. So investigation of first UTI is very, very important. And the rest, that is vaginal synecdoche, obstructive uropathy, neurogenic bladder, conjugal myopathy UTI, drugs, there are other causes. But what is commonly seen is a improperly managed and poorly investigated first UTI, associated constipation and phimosis. So that was the cause. So in that case, we investigated. Again, it was a second network of UTI, 80 to 100 per cell, and culture is awaited. So, Dr. Daruru, what minimal investigation would do in a first case of UTI, first type of UTI?
The first itself.
Yeah.
A minimum, because already it has been subjected for urine culture. Yeah. So after the treatment, he should have been called back, and at least a ultrasound should have been done to rule out any persistent cystitis or any congenital abnormalities which can show us a cause for the infection. That has been missed in this case. So a complete urine analysis plus a ultrasound of KUB should have been done of calling the patient, which has been missed here.
Yeah. So Dr. Yagnesh, what is the take on this urine strip test for UTI?
There are two varieties of urine strip tests: leukocyte esterase enzyme test as well as nitrate test. Yeah. Leukocyte esterase is a product of the leukocyte which is present in the urine itself, or the nitrate which is a product of the bacteria. So by means of doing these two tests, we confirm the presence of WBC as well as bacteria in the urine. So both these are indicative of the infection. So it has 50 to 70% sensitivity and specificity. So as a primary screening test, it is a good test. And along with the urine routine micro and along with the presence of bacteria in the urine itself, it gives almost 100% predictivity of the urinary tract infection. So it is a good test.
Very nicely summarized. So when a child has got the first UTI, urine examination, strip test you made if a microscopy is not available. A culture is a must. We cannot diagnose UTI in absence of culture because simple pyuria means presence of WBC. But absent culture does not indicate the child is UTI. It can be occur with stone, It can occur in a case of Kawasaki disease. It can occur some other febrile illness. So culture is a must, and at least imaging is required, irrespective of the age of the child. Imaging is. So these are four indications which is baseline as far as first attack of UTI is concerned. And what Dr. Yagnesh is saying, that what is commonly missed is a gram stain of an uncentrifuged urine. And if you look at the gram stain, it was sensitive 93% and specific 95%. So from tomorrow onwards, I plead to all of you that when you do a urine, always ask this gram stain. We always talk about culture, strip test, microscopy, whatnot, but simple gram stain is very, very important. And when the culture facility is not available, probably this gram stain facility can replace the culture as far. So we can look at this specific 95%, look the sensitivity 93%. So NA, pyuria, strip test and gram stain all should be combined. But if every culture is not available or it is available, it is a good habit to have always routinely a gram stain along with the urine routine micro. So gold standard is I already told you. Now, Dr. KHEYA, how will you store urine? How will you collect urine? Sorry, how will you store it, and how will you interpret the culture report?
I think all of you know there are different methods of urine collection,
but they are very cumbersome.
And they are very cumbersome, and it will also depend upon the baby and the condition of the baby. If the baby is very sick, admitted, you can go for a suprapubic culture. If you have a, especially in a neonate, often we do with an ultrasound. And but in a not that sick a child, it's better always to do for a midstream in an older child or a clean catch urine. So in an older child who can follow your commands, you can tell them to pass and just collect in between. That is what we call midstream clean catch. And the clean catch in the younger children, you can, it's always better some two parents are involved, one is holding the vial and another keeping the baby in the prone position. That helps to collect the urine without any contamination. And a prior wash with the soap and water often helps, but it's always leads to a voiding of the urine. So that is, but you should not use any antibiotic solution to clean the genitalia. This is very important.
How will you
and as you have already shown, it should be cultured immediately, and if there is a delay, it should be refrigerated and should not be kept in room temperature. And if you do a suprapubic aspiration, any number is significant. If you are doing a midstream clean catch, that is what we do usually, a number of 10 to the power 5 colony forming unit per ml is significant. And in urethral catheterization, this should be avoided because it can lead to traumatic injury, hematuria, but in sometimes we have to do. And in that case, any number 10 to the power 4 is important. But what message I would like to give, just avoid doing a urine sample on a urine collected on back. That should never be done, and that should always be a contaminated sample.
So for back samples should be thrown away, should not be taken. And suprapubic, though we are afraid of, it's a very good tool, and any number of colony count is highly suggestive of UTI. Now, what are the imaging guidelines? What is the best time to do, Dr. Rajendra?
So now for the imaging, if the child is less than 1 year, even if it is a first urinary tract infection, the child would require urine routine, urine culture, ultrasound.
No, only talking about radio culture now. Radio imaging.
So the ultrasound is must in all cases, but ultrasound in less than 1 year, you should do an ultrasound followed by a DMSA scan after 3 months, and MCU to rule out reflux. MCU can be done in between the ultrasound and DMSA scan. But whenever we are doing MCU,
yes, please.
Prophylaxis, antibiotic prophylaxis to the child. That can be given orally or that can be given injectively. When we talk about more than 1 year, 1 to 5 years, we should do an ultrasound and DMSA scan. And above 5 years, only ultrasound is sufficient.
So so it all depends on if it is a first UTI, you have to look. USG is a must. If the scan is normal, then if the child is less than 1, you give MCU as well as DMSA scan. DMSA after 2 to 3 months and MCU after 2 weeks, because MCU retrograde procedure is there. It may cause the ascending infection. So you have to first treat the infection. If the child is totally symptom free, you do MCU after 2 weeks, and in between you can give a antibiotic prophylaxis. If the child is from 1 to 5 years and USG is normal, you go for the DMSA, and FCU is invasive, is required only if DMSA scan is showing a scar. If it is more than 5 years, if it's a normal USG, then further MCU and DMS is not required. But remember, if USG is abnormal, then you have to do both MCU as well as DMSA, irrespective of the age of the child. But most important that if it is second attack or recurrent UTI, all the three investigations are to be done irrespective of the age of the child. So here is the recurrent UTI. So this child will be required all the investigation. And I already told that USG within first 2 weeks, if it is a complicated, otherwise on follow-up. So if a severe UTI, if there is a complicated UTI, you do it within first 2 days. Otherwise, your UTI can be done on a first follow-up, MCO after 2 to 3 weeks to avoid retrograde infection. And DMSA, if it is done after 3 months, it will avoid a false positive result. So that is about the, because if you are doing it immediately, there will be a pyelonephritis, and this pyelonephritis on scan will look like a scarring. So there is a pseudo scarring, and there will be a false positive. And that is the reason that you have to do the DMSA after 2 to 3 months of the resolution. So in index case, ESBL Klebsiella was found, which was sensitive, treated according to amikacin, which was treated according to the. But what is more important that we imaging was done and was suggestive of the vesico-ureteric reflux on the right side. So, but when we did on the this DMSA, there was a bilateral vesico reflux. So, what advice will you give to this child, Dr. Daruru, on discharge?
Sir, any sick child can have a vesico-ureteral reflex. That is a normal thing. That's what we find. Somebody, if they have come for bacterial infection in the lungs and other things, if they are under 1 or 2 years, the vesico-ureteral reflex is also, and GER also may be formed. But here, as the case is a urinary tract infection, we have to give significance to it and treat as per the protocol.
What,
so
Doctor? Yeah. KHEYA, what advice will you give to the child is on recurrent?
Just to prevent recurrence, we should tell the parents to give lots of fluid to avoid constipation. If there is phimosis, in this case, in a recurrent case of UTI, we should advise for circumcisions. And of course, you should all investigate. And if there is a grade 4, more than grade 4 VUR, then we should go for a prophylaxis also.
Yeah, so that is more important.
Correction.
Yeah, personal hygiene, hygiene of the genitals, plenty of the fluid, taking care of the constipation, frequent voiding, at least not to hold on. They are all important. But if there is any of the imaging shows vesico reflex, which is grade 4 or 5, bilateral internal, chemoprophylaxis is very, very important. And suppose the child has a first attack of UTI, during any febrile episode, child must be subject to urine routine. And if urine routine is suggestive of cell, urine culture is a must. So any febrile episode should be taken as a potential case of UTI and should be treated accordingly. So we can prevent further recurrences. That is all about the discharge. So in our case, there was a primary VUR, grade 4 on the right side and grade 2 on the left side, and that was the cause of the recurrence. So message that even if it is a first attack, you always investigate. Recurrent, always thoroughly. Even if it's a complicated, uncomplicated, complete workup is required. Renal function has to recover, and you have to take care of the constipation and malformation. This will address the issue of the recurrent UTI. So let us move on this third case. A 27 days old male child, full-term vaginal delivery, 3 kg, was having some few pustules on the thigh, which subsided of its own from day 10 to 14. But child was having a fever, excessive crying, and refused to take food for 2 days. Mother noticed that there was more crying while handling the child, especially when the diapers are, mother wants to change the diaper, there was more excessive crying. Temperature 102, there was diminished movement of the left lower limb. There was a swelling on the left knee, on the lateral aspect of the heel on the left side, which was tense, red, and tender. Anti-frontal is normal. Rest of the signal is normal. Child was admitted and investigation. So what it could be?
So this could be a case of a septicemia, which is with localization over the left upper thigh as well as knee. So probably it is an either septic arthritis or osteomyelitis of the left femur. Yeah. So this would be our primary diagnosis in this case.
And we investigate this child. You can see that there is a polymorphic leukocytosis. CRP was very high. Blood culture was sent, and urine culture was sent. So, Dr. KHEYA, how will you rate this septic screen?
So this is a total count is more than 15,000. So usually less than 5,000 or more than 15,000 should be taken as a sensitive. The CRP is high. Actually, we should look for the other things like NC, absolute neutrophil count, which is more actually. It is more than 1,500. It is 74% of this 17,800. And we should look for other things like band cells, toxic granules. These are the counts for the what we do in a neonate sepsis screen. These are the 5 parameters that we see. And this is, we will take it as a sepsis positive, and we should immediately wait for the start antibiotic, and before that we should send the blood culture as it has been sent to this, and also a urine culture. But I think we should go, because the focus is restricted to the hip and the knee, so we should go for an imaging on that part also.
That they were coming. What about CSF?
So in a newborn, it's a late onset sepsis. So it's a late onset sepsis. If there is in a newborn, you should do a sepsis screen as we have done. We should do a blood culture, urine culture. We should do a chest X-ray and a lumbar puncture, irrespective of the focus. So all these are mandatory.
So that is very, very
important. Chest
important.
X-ray and a lumbar puncture is a mandatory in this case.
Yeah. So any sick newborn is there, you have to have a complete evaluation required. Not only sepsis screen, but this sepsis screen should also include CSF routine culture, urine routine culture. Even if we have found clinically that there is focus in the osteoarticular system, but always all thorough investigation is required. Now, which antibiotic would you start, Dr. Rajendra, in this case?
So now the commonest cause, this is a community acquired infection, and this is probably a staphylococcal. Staphylococcal is the first organism we should really think about. Then there can be a streptococcal infection also, which can give rise to septic arthritis. So staph, and that too community acquired, because it is a late onset sepsis. Probably it would be a methicillin sensitive staphylococcal as far as the wide guess is there. But there can be 15 to 20% community acquired MRSA also. So we should start anti-staphylococcal antibiotic. First generation cephalosporin should work in these children. And once we get the pus culture report and other things, probably we can either step up or step down the antibiotics.
Which first generation cephalosporin would you start?
Cefazolin, sir, first generation cephalosporin.
Yeah. Dr. KHEYA, do you what idea have? Different idea?
Yes, sir. So this is a 27-day-old. This is a neonate. So in that, you have to think of other than staph, strepto, or gram-negative.
Gram-negative, exactly.
So we have to give a coverage for gram-negative, strepto, and a staph, which may be a methicillin sensitive or a in this case, there was skin lesion. So there is a likelihood that this will be a staph, but we have to give a gram-negative coverage.
So yes, so what would you give?
So I would give a third generation cephalosporin along with a staph coverage, either flucloxacin, oxacillin, or vancomycin. We have to see.
So you give ceftriaxone plus cloxacillin you want?
So initially we start with MSSA only, unless the baby is very toxic and there is a history which might suggest a MRSA. Like if there is a history of someone in the family having a MRSA infection, or recent history of antibiotic intake, or if there is a skin lesion which is rapidly going into spreading necrotizing fasciitis or things, then we will think of MRSA. Otherwise, in this, we should think of MSSA first. But of course, the culture, depending upon the culture or depending upon the condition of the baby, if it deteriorates, we will shift.
Yeah, so there are, yes, Dr. Darur.
Sir, there are two focus what we are seeing here. One is the knee joint, the other one is the somewhere in the femur. So if both joints are hip joint and knee joints are involved. So it is a case of septicemia with involvement of the entire thing. So we have already planned to do a CSF analysis. So we would like to have a higher antibiotic than the ceftriaxone.
So because it's a newborn,
vancomycin should be started, sir.
Because it's a newborn, number one, there's sepsis there. Number two, it's a deep tissue infection where the penetration drug is not going to be that good, and MRSA is always rising, and therefore we will give a ceftriaxone plus vancomycin is this. So the likely bug has
sir, it is a fast progressing disease because in just 2 days it has involved knee and vancomycin should be added upfront.
So we have started ceftriaxone and vancomycin. These are the bugs that already discussed: Staphylococcus, Streptococcus pyogenes, and gram-negative because the newborn is there. If it is a low birth weight immunocompromised child, then we think of the Candida. In this case, it is not applicable. And so we started separately. So, when will you plan this debridement or aspiration, Dr. Yagnesh?
Yeah, once we had come to the primary diagnosis of a septic arthritis in the left knee, as well as the involvement of hip. So one should first go for an imaging studies along with the giving an antibiotic. Thereafter, what is the result of the imaging studies? Depending upon that, you can plan debridement and sending for the blood pus for the culture examination.
Yeah.
So various imaging modalities we have for the bone that should be offered. The first and the foremost imaging modality that one should offer is ultrasonography. Ultrasonography will give you not only the size of the joint space, that is in septic arthritis, but it will also give you an anatomical finding or anatomical delineation of the soft tissue as well as the bone. Whether the bone is involved or not, that will also be delineated. Another advantage with USG is USG will guide aspiration. USG guided aspiration is can be performed if required. So USG is the modality of choice here. Of course, MRI is the comparable modality, but it may require a sedation in cases of our children patient, and it is costly, may not be available everywhere. So both these modalities, USG and MRI, is the good modality of radio imaging for it.
So these are the cases that newborn is there, septic child is there, and osteoarticular infection, if not taken care properly, there may be a chances of permanent deformity, like shortness of limb, inequality of limb. So we have to very, very aggressive. We have to act very fast, and therefore a source control is very, very important. And how we can do a source control? Either with the help of the aspiration of the pus, and as well we have to do a tissue debridement. It will have two ideas, not only source control, it will give a critical sample for the analysis, but blood culture may not be positive. So a blood sample for the microbial diagnosis also available. And once this debridement is done, pus is removed, the penetration of the antibiotic at the site of infection will improve. And this can be aided with the help of the proper imaging. And as far as image is concerned, USG is always there. MRIs, if available, should be provided upfront because it will help to rule out underlying osteomyelitis as well. And as far as plain X-ray is common, is not much helpful because the in X-ray there may be a soft tissue edema, but other lytic lesion occurs very, very late. And by the time the diagnosis made, it will be too late, and child may end up with a morbidity. So it is very, very important that USG and MRI should be given as early as possible. Debridement should be done as early as possible, and a first dose of antibiotics should be started as soon as possible once the culture has taken care. Yes, Dr. Daruru.
Sir, once you think about septic arthritis, involve the orthopedic surgeon. He will do the aspiration, and the very next day he will take up for the case for debridement.
Yes.
So this similar case we have presented in the last conference. So it is the first rule is if you think osteomyelitis,
that is the
involve the orthopedic surgeon.
Yes,
get
point
the
well.
aspiration, debridation.
Upfront, it should be provided upfront. Yes, agreed. Yeah.
Right,
so in that USG was done, which was suggestive of collection over the hip. There was collection over the knee, anterior to femur, and some collection joint, which is a case of septic arthritis. And with the fluid which was found was thick, hemorrhagic, and it yielded Staphylococcus aureus. But fortunately, it was sensitive to oxacillin. So, Dr. Rajendra Bhai, which type of staph is this? MRSA or MSSA?
Sir, this is methicillin sensitive.
Yeah. So, so Dr. KHEYA, now we have started septal vancomycin. What will you do?
So, if you are thinking it to be a methicillin sensitive,
no, not thinking.
Not thinking. Now it is there.
Now it has been proved. So you can come down, but sometimes if the baby is improving, we continue with the same.
No.
So,
I think what Dr. Yagnesh
ideally we should come down. That's what I'm saying, sir. Practically we continue, but ideally you should come down on oxacillin, or because flucloxacin is now available also, so we should come down. But sometimes it will be seen that if the baby improves, the vancomycin drug is continued, which should not be done.
So the message that I want, 1 minute, Dr. Yagnesh, we will not confuse here. Number one,
I understood. I was just joking.
important point message that once you are the sensitive report, you have to modify.
De-escalate.
And you are doing it in a very scientific way. Here, it is a MSSA, there is no point in continuing vancomycin. Number one, because toxicity is there also. Second thing, what is important that if culture is negative, then it's all right that you may not you continue vancomycin. That's all right. But once the culture reports there, sensitivity is there, then I think we should go down. We should not continue with the vancomycin. So here it was MSSA. Now blood culture was positive. So how does it make a difference in this case?
So
had it been first culture is positive and blood culture positive.
It is confirmatory diagnosis.
Culture is also positive.
But will you help some other way? Anything? It's a bacteria. Yeah. Yes, Dr. K.
Yeah, it will decide the length of the antibiotic. So we can continue the same antibiotic with de-escalation, removing the vancomycin, and we can continue with the ceftriaxone at least for 3 to 4 weeks. So that will decide the duration of the therapy. That's all.
Yeah. So what is the duration in osteoarthritis infection, Dr. Rajendra Bhai?
So the duration in septic arthritis is around 4 weeks, and if it is osteomyelitis, probably it would be 6 weeks. Now, recently the Nelson has reduced the duration to 3 weeks and 4 weeks in both the cases. But now IIP guideline has still 4 weeks and 6 weeks.
Yeah. So by and large, we continue for the 4 weeks. Probably it is MRSA, we continue for the 6 weeks. And if it is MRSA, bacterium is there and the child is not improving, then other search for the septic focus may be there. In that case, repeat lumbar puncture or repeat echo for the infected areas may be required. But here there is MSSA, not the MRSA, so this does not come. So if ectodermia is there, means blood culture is positive, the duration of the treatment will be little longer compared to a non-bacteremic disease. So that is the message that I want to show. And if it is MRSA, you have to be very careful, and it may require 6 weeks of the treatment. So after 7 days of the therapy, child was all right, and CRP was 1.5. So as far as this arthritis is concerned, in a newborn, which joint involvement is dangerous? Anyone can take. Dr. Daru, you want to take this?
Hip joint is the most dangerous, sir.
Yes, sir. Dr. KHEYA, what do I think?
So the weight-bearing joints, the joints, usually these are the joints which are involved, the hip and the knee, and these are the joints which have a synovium. Within the synovium, the metaphysis is there. So associated osteomyelitis is common. There is a damage to the cartilage that leads to a chronic problem like leg discrepancy, restriction of movements of joints. So these are the joints which should be taken care of. And as most of the septic arthritis in younger children is due to a hematogenous spread, so these are the joints which are mostly involved, the knee and the hip, and these are the dangerous.
In the child who is less than 6 months, it is very important that you can see this a transfacial vessel and the vessels, and these vessels
bend at that junction.
And these vessels are communicating from the metaphysis to epiphysis. So there is a spread of infection is staying. So simultaneously there will be a septic arthritis as the osteomyelitis in 30 to 40% of cases. So you have to be very common. Second, the periosteum is very loose. There are all the chances of developing a pus pockets. So, and as rightly said, that metaphysis of the shoulder, hip, head, head of the femur, and ankle, they are always intracapsular. So the damage to the growth plate is very important. Otherwise, it causes a damage, and there will be a shortening of the limb. So there will come many deformities there, and that is why early debridement, early aspiration, early source control of infection, and exhaustive treatment is very, very important. So osteoarthritis infection are commonly missed. It is associated with long-term morbidity. You have to hit very hard and fast. Long duration of antibiotic courses are very, very required, and MRSA is an emerging threat as far as the bone infection is concerned. Here the next case, a 6-year-old girl vaccinated as per the corporation card, otherwise healthy. There was 2 episodes of vomiting and some fever one day. So fever was not significant. Loose motions with colic abdominal pain after coming back from the picnic. With local doctor treatment, all other symptoms subsided, but abdominal continued, and someone has asked for abdominal sonography. And if you look at the sonography, all viscera were normal with normal echo texture, but there were multiple mesenteric lymph node, that is size 1.3 to 1.3 centimeter and maximum largest. So this is a case of mesenteric lymphadenitis. So which lymph nodes, can these lymph nodes cause abdominal pain? Are they significant? And which are the characteristics that makes that this lymph node be suspicious or significant? Anyone?
Sir, this is a child with have mesenteric lymph node. These lymph nodes are definitely larger. That they are more than 15 millimeters.
Yeah.
So they are significant. But
Yes.
at the same time, the lymph nodes can cause abdominal pain, but that is not to be treated at this juncture because it was some gastrointestinal infection which has caused these lymph nodes to enlarge and cause some discomfort in the child. But there are other lymph nodes. If the lymph nodes are caseated, matted, or they are at an abnormal site like retroperitoneal lymph nodes, aortic lymph nodes, para-aortic lymph nodes, irrespective of their sizes, they are significant and they need to be investigated over a period of time.
Yeah. So it is not the only size, but if the lymph nodes are multiple, conglomerated, if there is central necrosis, if they are situated near the vital structure, if there is distortion of the local anatomy of the nearby structure, then these lymph nodes are very important and they require investigation. But a non-specific lymph node which find in our duty to UGC usually does not require much attention. Only a reassurance is required. And how will you manage this mesenteric lymph node, Dr. Yagnesh?
Yeah, we do not require any antibiotic. Only hydration and symptomatic management is all that is required in this case.
Yeah.
Usually, it is a self-limiting condition. The child will be okay within a couple of days.
Yeah.
So no major investigation or no major treatment is required.
Yeah. So if the child is asymptomatic, look other causes of the abdominal pain. Close follow-up for fever, not gaining weight, anemia and loss is very important. If the symptom persists, not the lymph node, symptom persists, USG may be repeated. And however, Dr. Yagnesh has already told, repeated deworming and repeated antibiotic courses are not required. So this does not require any antibiotic courses. A close follow-up may be required, especially in a symptomatic child. If the child is asymptomatic, you have done USG for some other reason and you have found that there is a mesenteric lymph node, probably it does not require any attention or long-term follow-up. And this we will all discuss which lymph nodes are significant. So we'll skip this. We're all done. So treat the patient and not the report. Analysis of the clinical feature is very important and clinical correlation is required as the mesenteric lymph nodes are concerned. A 11-month-old child, weight is 7 kg, so little less, is vaccinated as per the urban health center. BCG scar was absent. There was a long illness of 3 to 4 weeks. Child was admitted twice for so-called Walray without any investigation. And liver was 2 centimeters, some mild pallor was there, some mild tachypnea was there, and child needs a minimal oxygen to maintain the saturation. So anyone can take, what does it look like from the history? So there is a
child,
yeah.
sir, the
Yes,
child has anemia, he has hepatomegaly, and he has oxygen dependency. That means he is having some respiratory distress.
Yeah.
So the lung is involved, the liver is involved, and there is pallor. So
Yeah.
the hematopoietic system is involved. So it has to be worked out whether it is a normal child or it's a immunocompromised child or he is having some hidden disease, which commonly we can rule. We have to rule out tuberculosis and other things. It requires complete investigation.
So any fever or cough which is more than 2 weeks needs an investigation. So these are classical X-ray. You can see
Miliary tuberculosis.
Miliary tuberculosis.
Yes, miliary tuberculosis appears to be.
Count is high, CRP is high, hemoglobin is very low. So the classical case of miliary tuberculosis. So Dr. Rajendra Bhai, would you start AKT or would you go for some other extra investigation?
Sir, this child is having miliary tuberculosis. There is no clinical doubt on this case, but at the same time, we need to confirm the diagnosis by doing some tests. And the commonest test which we should do is basically a gastric aspirate in this child because the child is too small. So we can get a gastric aspirate by giving a gastric lavage, and that too early morning sample, preferably for few hours of nil by mouth. So that would give us some diagnosis. We can do a ZN staining in the child. At the same time, we can send it for a CB-NAT test also.
So yeah, so point is very clear that though it's a clinically confirmed diagnosis of miliary tuberculosis, a microbial diagnosis is a must. In 2020, we should not start. We must opt for the microbial diagnosis, and that is done with the help of the CB-NAT as well as with the help of the ZN stain, and also a MIGAT culture is also required. What about lumbar puncture? Dr. Daruru.
Can be.
So it is a must. Yes, Dr. Daruru, please.
Yes, sir. the tuberculosis elimination program says that don't start any drug unless until you prove that it is tuberculosis. All efforts has to be put in. Suppose your gastric aspirate is negative, then the CB net is negative. Definitely you have to do CSF analysis and you have to rule out.
Irrespective of whether these are a CSF is must in this state.
No, CNS signs are there or not, it has to be complete procedure.
So the miliary it is a hematogenous spread, and therefore we have to find out whether signaling has taken place in the brain or not. So CSF is always must in all the cases of miliary tuberculosis. Number one, microbial diagnosis is always required, even if it is a clear-cut case of miliary
tuberculosis clinically.
So in that, what Dr. Rajendra said, two samples were AFP were negative. We did a CT test. We saw multinodular opacity of seems to be infective. Both hilar glands are also enlarged, and HIV was not reacting. And parents saying father was having a fibrocavitary lesion. So it is a very history of contact, screening of the parents, HIV, and CSF is very, very important as far as the miliary tuberculosis is concerned. Now, in that case, we have done the CSF and it shows that protein was 75, cells are high, 80% poly, and AFB was absent. But CBNet was positive and suggestive that rifampicin resistance was detected. So we are dealing a case of CBNet. Now, what is the importance of CBNet? Dr. KHEYA, why we should give CBNet in all these cases?
So as CBNet is a point of care test, so it gives you a rapid diagnosis in a suspected case of tuberculosis, because we know other methods of molecular diagnosis in microbiological diagnosis takes time. The solid culture takes a long time. Even the LPA takes around 3 days. So it gives you a quick results within hours. So we should go for it. And there are certain advantages of it because it's a very short run. As I said, it is reasonably satisfactory. Sensitivity is quite high. You need not have a very expert person to run it because it is not observer. It will not depend on the observer. And you can get the result very quickly. And moreover, very, very important, you get a clue to the drug resistance. So if you get a rifampicin resistance, which is not possible by any other method. So you get a clue to the rifampicin resistance.
So
but the thing is,
so in 2014, we were told that it should be provided only MDR cases, non-responding cases. But after 2014, the message is very, very clear that on the TB suspected cases, it should be given upfront. Results are available only in just 2 hours, and it gives idea about the rifampicin. But as far as CSF is concerned, a large quantity is required, even 7 to 8 ml. Minimum 5 ml is required. That will give a better yield as compared to the small amount. So always have a good amount of the fluid, minimum 5 ml. 7 to 8 ml is better. Yes, Dr. KHEYA.
This is what I want to see. Don't send CBNet in 3 samples. What we remember as BUS, that is blood, urine, and stool. So in other fluids, you can say, of course, the sensitivity will vary.
Okay. Okay, good. Yeah. But suppose in this case, CBNet is negative, what will you do? Suppose, let us presume that CBNet was negative, CSF, everything is normal. What will you do in this case?
You can go for culture.
Diagnosis.
We should go for culture.
Culture will a little more time, but what will you start in that case? So you should treat it as a clinically diagnosed tuberculosis. Of course, culture is required, but you treat it as a clinically diagnosed tuberculosis. So these are new term now that when X-ray are there, microbiota is not there, we call it a clinically diagnosed tuberculosis, right? So the new terminology in the
sir, if you get a rifampicin resistance case in CBNet, then you should use another method to prove that whether it is a multi-drug resistant tuberculosis.
I'm coming to that.
Also,
I'm coming to that.
Should consider.
I'm coming. Okay. So, Dr. Rajendra Pai, how will you proceed once the CBNet report is there? I'm coming to that only.
So now the CBNet has said that it is a rifampicin resistant. So it can be a monodrug resistance or it can be a multi-drug resistance. So we really do not know. So we really need to do more investigations or tests to diagnose that multi-drug resistance is there or it is only a monodrug resistance is there.
Yeah. So so as rightly pointed, we have to CBNet positive, it does not end the story. You have to find out what about the other drugs, what about the isoniazid, what about the pyrazinamide. So for that, so if MTB is detected, but rifampicin is sensitive, that's a case is very clear. You are dealing with a drug sensitive tuberculosis. But If MTB is positive and rifampicin resistance is detected, then you have to isolate whether it's a new case or a retreatment case. If it's a retreatment TB case, treat with the regime for MDR TB and offer a second line drug wherever available and send it for the culture before that. If it is a new case, treat with the regime of MDR TB after reconfirming rifampicin and with another technology. But you have isolated, you have detected AFB either in the smear or the CB net is positive. Then in the same smear positive cases, you reconfirm your sensitivity with the help of the line probe assay. So line probe assay should be subjected only to a positive sample, whereas CB net is to be subjected to all the sample, whether they are negative or positive. So this line probability is to reconfirm. And if the smear negative case, then offer the culture, either liquid culture or solid culture. Liquid culture is better. And if the culture is positive, then this positive culture isolate must be subjected to LPA. So message here that once the rifampicin organism detected, rifampicin is there, you have to find out the drug and sensitivity report. And either for that, you can take help of the liquid culture medium, or you can take the help of the LPA. But LPA should be offered only in cases where the culture is positive or the smear is positive. So it is only required for the smear positive cases. So that is the message that I want to go. That is about CVA and the drug and sensitivity report as far as the tuberculosis is concerned. So in case of tuberculosis, a microbial diagnosis must, no matter whether it's clear-cut case clinic on clinical background. CBNet has revolutionized the TB management and should be provided upfront. And every attempt should be made for all the microbial diseases. And once it is detected, then always go for the drug sensitivity report. So that is all about this. Now, to all the expert, when will you suspect a non-infectious fever? Only give 2 markers, 1, 2, 3, 4. 2 markers of non-infectious fever. Dr. Rajendra.
Sir, 2 markers for non-infectious fever.
Yeah.
Clinical or laboratory?
What? Clinical
or laboratory?
Whatever is coming.
Clinical in non-infectious illnesses, basically the interfebrile illnesses, the child looks very good, and a single dose of paracetamol works better in these things.
Yes.
About the infections which are ruled out and you have inflammatory markers very high.
Yeah.
Then these are the conditions where you should think about non-infection.
Dr. Yagnesh.
Almost 25 to 30% of
only 2 statements. Dr.
Okay, thank you.
We can have a drug fever, and so the history is important. Whether we are on a certain drugs like ceftriaxone, it can cause a fever itself.
Yeah.
So drug fever is another issue where one should be very careful.
Dr. Daruru.
Sir, connective tissue disorders are to be ruled out.
Yeah. And Dr. KHEYA.
So I think they have all said connective tissue is gone, drug fever is
So,
gone. Another 2 very important is malignancy. So if you have a persistence of fever and you are suspecting some bone marrow suppression or lymphadenopathies, think for hematopoietic malignancy and periodic fever. Periodic fever we should, very rare, but we should think of.
So
non-infectious
any child who has a fever but looks ill, toxic and very excruciating bone pains especially night, you have to think of serious like leukemia. But if the child has a fever, but the fever is rhythmic and response to paracetamol is good, and even if the fever persists longer time, child is not looking ill, probably it tells that probably you are dealing with an immune mediated fever. And along with this, there may be a rash, there may be features of vasculitis, and as the day progresses, child might have hyperosplenomegaly, lymphadenopathy, or sometimes growth failure. And majority of the cases, the ESR will be in 3 figure or at least more than 50. So that is all about the non-infectious. So with this non-fever. So with this is the end of the panel discussion. Thank you all the panelists and all the
thank you, sir. Thank you,
participants.
Thank you.
If you have any question, we are very keen to answer.
Yes, sir.
Thank you so much. Yeah.
Thank you very much, Dr. Abhay, and the experts here out here, Dr. Yagnesh, Dr. Daruru, Ranganath sir, Dr. Khadke, and Dr. KHEYA. It was, in fact, an exciting journey through which has evoked interesting thoughts, right from I think the throat infection down there to the meningitis, to the typhoid, in between the typhoid fever and mesenteric adenitis. And you are taking an older child and right to a newborn. So that is the right mix, I believe, 6 cases or 7 cases which you have gone through the clinical presentation and the markers. Of course, sir, we have a lot of interaction in the platform. Of course, it has to be interesting. Infectious diseases never goes without raising your eyebrows. Maybe whatever you convince them, some may not be convincing. And we have got Dr. Randhava and otherwise Dr. Venkateswaran, Dr. Shiba, as well as Dr. Jayakumar, Dr. Renu, the president of Aurangabad branch. We are so grateful that all of them have interacted quite well in the platform. Sir, it's something like one first question regarding that you said about herpetic stomatitis we are discussing. I mean, moderator or any of the panelists, let them take role of encephalitis, risk of encephalitis following severe herpetic stomatitis. And for that reason, would you have got any role for acyclovir or topical systemic?
Yes.
Severe herpetic stomatitis. Dr. Shiva has put this excellent question, in fact. Would you anticipate this risk at any moment when you come across a herpetic stomatitis? Do you say the parents, there's nothing to worry, you go home, sleep comfortably, and they come back with an issue? What exactly is your take there? Or would you do something in anticipation?
Yes, Dr. Rajendra, you answer. Dr. Rajendra.
Sir, basically, when an immunocompetent patient comes with a herpes stomatitis, he has to improve in 48 to 72 hours with symptomatic treatment. If the patient is immunocompetent, then he will definitely respond. But if he is an immunosuppressed child, probably the things would be different. If the symptoms and signs prolong more than 48 to 72 hours and the adenophagia worsens, there is a role of acyclovir which we should be offering in the child.
Even for an immunocompetent child?
Yes, sir. If the child is deteriorating clinically after three days of having this, then probably we should be giving acyclovir. I think Abhay sir would be in a right.
Yes, sir. Actually, our first case was herpes, but not the herpes simplex. Number one.
Yes, sir.
Number two. Number two. Herpes simplex when occur in a younger baby, a newborn or a less than 3 months, the chances of dissemination is very, very high. We have seen number of cases of herpes labialis, but probably they do not go for this encephalitis. So, of course, encephalitis is seen with herpes simplex, but at this age, I think herpes simplex has different presentation. They will have a neuropsychiatric manifestation, focal syndrome, focal sign, focal convulsion, and grown up children. But because the child has got the herpes lesion in the oral cavity, the complication CNS complication is not that known. They are straightforward cases. They are of course, if the child is immunocompromised, if the child is neonate, if the child is less than 3 months, they have more chances of dissemination. But in a grown-up child, it's all sort of a local lesion and does not go for the complication. They can have herpes simplex, encephalitis is a different thing. But because they have got the oral lesion, they are going to complicate. It's not that.
Dr. Abhay, can I put it like this? If there is a duration of something like 5 days, child is not responding, take it as a scenario, would you opt for something else at that moment?
But we have to look at the CNS. What is worried about CNS? The child is absolutely conscious. There is no point in thinking of the encephalitis. We can give a acyclovir for the oral lesion if there is very severe pain, but most of the time it is not required.
Of course. And I have got a query right here alongside. You have been discussing about the oral lesions and the viruses. Coronavirus, which corona you are talking about? Just for the recap. You said about corona as one of these.
There are 4 common
strains. Just let us be appraised about the strains because we are not talking about N19.
Even in this slide, COVID-19 can cause this type of lesion, but even itself corona is responsible for 20% of cases of tonsillopharyngitis. Out of all viral lesions, coronavirus, forget about COVID-19. Coronavirus has a predilection in 20% of cases of viral tonsillopharyngitis.
Has there got any strains? Can us be informed about the strains?
Any corona.
N19. Any corona.
Any corona.
Or age-old coronas. Okay, fine.
Any corona.
So a lot of discussion is there in the platform regarding the typhoid, Vidan and monospot. Would you please take this to two lines, typhoid and versus monospot?
So as far as any panelists want to ask, or go ahead with the answer. Okay. So as far as the typhoid, monospot, and serological tests are concerned, number one, we have stopped doing it. We have also stopped doing viral tests. Only we are doing is the blood culture. Why? Because if your child is toxic, you have to take the blood culture, febrile, wait for the report, start the antibiotic. Number one. But if the alternative diagnosis is found, then we will stop the antibiotics. But as far as typhoid is concerned, there is lot of discrepancy. In our South Asia, like even Pakistan, Bangladesh, there are a lot of typhoid cases. And WHO has done a study. And the correlation with the blood culture is very low, in the tune of 15 to 18%. So positive does not confirm, negative does not rule out. So what is gold standard is a blood culture. So what we see, if the typhoid or IgM is positive, you have to clinical correlate. If you think that you're dealing with a typhoid, you take the blood culture and start the antibiotic therapy. But so if the blood culture is negative, clinical response is not that probably you are dealing with a fever which is not typhoid. So in a nutshell, typhoid or monosport test has no role. They are useful only in cases where the flood or outbreak situation for the epidemic purpose, where a pre-test predictability is very, very high, positivity is very, very high, then it is required. But in a routine individual clinical practice, it is a blood culture, and blood culture.
Alongside, maybe having from any of the panelists, can be ceftriaxone given daily, once daily in endemic fever? And again, when there is cefixime, would you opt for cefixime, an oral drug in a child who is sitting pretty and happy?
So as far as ceftriaxone is concerned, it has got the I would say concentration dependent killing. It's a bactericidal drug, so it can be given once a day, but better to give twice a day because it will maintain the MIC and the blood level. So theoretically yes, but ideally it should give twice a day.
No, sir. About cefixime,
Cefixime, no. Cefixime should be given twice a day. I'm talking about ceftriaxone, parenteral.
Would you opt for it when the child is sitting pretty and happy?
Which one?
If the child is stable, he is not dehydrated, he is not toxic, you can opt for oral cefixime. That is
oral, but not once a day. That I want
twice
to say.
Oral cefixime twice a day for 14 days.
Yeah.
And you have to monitor the response to the cefixime for after 3 to 5 days.
No, already you have mentioned about
switch over to from IV to oral whenever the baby starts to take orally.
As soon as possible, you have to switch over. As soon as possible, you have to switch from IV to oral.
Fine,
and cefixime, you have to give a higher dose, that you have to remember in typhoid, to give 20 mg per kg.
Fine, sir. That was Dr. Shailendra from our friend from Guwahati. Now, Dr. Harikumar would like to know what are the instances when a Cohn's positive blood culture case can be considered significant.
Yeah, so Cohn's
negative, positive, Cohn's positive blood culture. When do you consider as significant?
Cohn's are very notorious. As far as the blood culture is concerned, they are very notoriously false positive. Why? Because they are the common organisms sitting on our skin. So if the skin is not properly taken care of before culture, you are going to get it Cohn's. So Cohn's in an immunocompetent child has no value. It has to be corrected clinically. So if the child is very low birth weight, on the gazettes, on the catheter, immunocompromised child, then Cohn's has very significance. Second, if you do a blood culture, report at what time it becomes positive. It becomes positive in 24 to 36 hours, or at the most 48 hours. It is a true infection. Most of the contaminants as a Cohn's will become positive after 48 hours. So if the child is immunocompetent, ignore it. If the child is immunocompromised, consider it. And the timing of the beep, we will call it timing of beep. If timing of beep is beyond 48 hours, probably it is going to be a contaminant.
So you mean it comes after 48
so
hours?
If we have multiple culture positive, then also think of contamination.
Yeah.
So if time taken more, multiple cultures, and if you get common cells, then
and you have two sets,
positive.
And you got a two set. If one is positive, other is negative, then you have to neglect. So your positive is to both the sets. Dr. Ramesh, you are not clear. I think you want to ask something. You are not clear.
No, sir. Doctor, there was a lot of comments regarding the collection of urine sample, and even Dr. Jayakumar or HOD from Amrita Institute has mentioned that the persons when you mentioned it is centrifuge urine and non-centrifuge urine, what exactly is the difference?
So if it is a centrifuge urine, if it is centrifuge, it is a 5 per high power pill. If it is an uncentrifuge, it is a 10 per high power pill.
Fine. So it should be very clear when the sample is taken. So it is done. Okay, sir. Then about the urine collection, even yesterday we had a session about the tic-tac method that Dr. Vijay Havale was demonstrating it, and it looks so informative, and the message was very clear. A bag specimen should not be used. Even an SPC can be done straight away. And alongside about the synovitis, Dr. Shiba would like to know something which is related to this. What's the best antihypertensive for a child with chronic pyelonephritis and hypertension? Chronic pyelonephritis and hypertension.
I am.
Maybe unrelated.
I see, when I am taking, I do not go beyond this amyloid. So I straight away go with the help of nephrologist.
Fine, sir. Okay. And there was a comment here on the platform, which is, I think, Dr. KHEYA has widely agreed to it. Better to give cefotaxime than ceftriaxone in children less than 2 months of age because of the anticipated risk of a cholestasis.
Yeah.
So there was a mention regarding ceftriaxone, so there was a discussion here. Okay, fine. Dr. Shiba again has pointed out, can't there be a possibility of the CGD, chronic granulomatous disease, in this baby with a severe disseminated staph infection? You're discussing a case with a staph septicemia.
But
so
it is
CGD,
see, any child who has got a suppurative lesion is a potential cause of CGD. But in particular, this case, child will be chronically ill. I don't think that this child requires this investigation for primary immunodeficiency.
And it was a neonate only, so it's very difficult to say. Neonate, they often present like this, and they may be even in a
if they do not,
who will be
if they do not
immunocompetent
respond, if they do not respond, if there is recurrent abscesses which amounts to IND, recurrent osteomyelitis, recurrent pneumonia, not thriving well, then it's all right. But the first simple case, MSSA was grown, responded well, so I don't think it's required.
Sir, one basic routine question as for the stool examination, Dr. Ayan Ali Siddiqui has put it. Please discuss incidentally found stool protozoa. What would you do? And drug of choice and duration, ova and cyst, what to treat? Parasitic.
Number one, why the stool exam was done? Number one.
Okay, sir, somebody has done it and we have brought the results to you.
Number one, see, we should not treat the report, we should treat the child. If the child has no diarrhea, no abdominal pain, doing well, eating well, playing well, I will ignore it. Even if the E histologica is present, there should be ingested RBC in it. See, presence of E histologica may be a carrier stage, but what is pathogenic that you need to have a RBC inside that. So if the trophozoite of the E histologica has a RBC inside, I will definitely treat, even if the child has this E histologica found of just like our routine. But if E histologica is there, which has no ingested RBC in the trophozoite, it's a carrier stage. I will not do anything.
And I think the message is very clear that you don't have to go after the ova and cyst as per the general practice, maybe in the homeopaths and other alternative system of medicine, which they are very fond of. One quick question here. In case of exudative tonsillitis, how to differentiate infectious mononucleosis and diphtheria?
So exudative tonsillitis is a bacterial infection. So it's a localized illness.
Adherent.
It's a localized. Yes, Dr. Darudu, please go ahead.
Sir, if it's an infectious mononucleus, you take a swab and just swipe it up, it will come off easily. If it's a diphtheria, it is adherent, it will bleed, and it will be difficult to peel it off, and the colors are different. Here, this will be ash colored, and there will be central grayish or black color near to the black color. But that is only a clear pus-like picture you will be able to see in the case of other pattern.
And secondly, infectious mononucleus are viral. And the virus are known to disseminate the body. So there will be hepatosplenomegaly, there will be rash, there will be periorbital edema, these 20 species. And when you give amoxicillin, thinking that is a bacterial infection, there will be a development of the rash. So generalized manifestation is infectious mononucleosis, localized infection, either it can be a tonsillopharyngitis or diphtheria. In diphtheria, there will be a bleeding when you try to remove the pus. And it can be unilateral also, one side. Whereas in case of tonsillitis, it's a bilateral symmetrical exudative tonsil.
Sir, that's very clear, sir. Thanks very much for that. One quick question for me. What is the relevance of bacteriuria, urine bacteriuria? You said many times bacteria 2+3+, some people are really worried and they bring this research to you. But do you find how any seriousness or any relevance to that?
Yeah. So presence of bacteria is directly proportional to the delay in the sending the urine to the laboratory. Means the urine has not reached to the laboratory in time, the bacteria is going to grow. So it has no significance. But if the urine exam is done within 15 or 30 minutes, this bacteria has significance. So again, they have to be correlated with the culture. So even if the bacteria is there, but culture is negative, it is not UTI.
Yes.
So by and large, presence of bacteria in the urine report routine should be neglected most of the time.
So fine, my dear sir, as well as the experts, it was a wonderful time traveling with you for about 1.5 hours, and really, actually, most of our good friends, more than 200 plus, 250 plus, have been logged in today from other sites.
Okay.
And Dr. Abhay Shah from Ahmedabad, Dr. Eknesh Papat, the current the chairperson-elect of ID chapter from Rajkot, Dr. DR Ranganath from Hyderabad, Dr. KHEYA GHOSH from Calcutta, Dr. Rajendra Khadke from Aurangabad. They were our dear who have been there with us today. And on behalf of IAP Kerala and all the participants who are out here, and my good friends from outside the Pan India, almost 50% of the participants are outside Kerala, as I've taken it now. It's quite good. We are all thankful to you for sharing some different perspectives or different thoughts on the infectious disease scenarios, and as you said, some pearls to take home. So thank you very much, sir. And it's now time for the organizers, Dr. Randava is all to conclude the session. Dr. Ajit Roy, Dr. Randava, all our seniors are around. I'm so happy seeing them still at this, the last part of the session. Dr. Venkaya Uchikonda is there. Dr. Balachandar, Dr. Narayan. Yeah, please.
Narayan, sorry, sir.
Yes, sir.
Hello.
Boliye, sir.
Okay. So last 2-3 sessions I have not been able to give the vote of thanks because of that problem. So today we have plan B. Dr. Ranjit, please be ready if I get exited.
Yes.
So today we had a great panel discussion on infectious diseases, various case-based, we had 7 to 8 cases. And we are lucky to have experts in the field of infectious disease, well moderated by our Abhay Shah sir. Everybody knows him because he has been fortunate to.
Balachandran, give me a minute. One question is pending here, and which I have missed actually. The participant is really eager to know about it. Dr. Prasanna Betala is there. Why you have no, what is the need for 1:5 concentration for blood culture? I'm sorry, I'm interrupting, but this is an interesting question, I believe.
What is?
So any of the panelists, 1:5 concentration for culture, you always insist on. Dr. Prasanna Betala would like to know. Why do you say 1:5 concentration is required?
Yeah, this is because the amount of bacterium yield is directly proportional to the amount of the blood. So if there is more of the blood, if 1:5 is ideal, in that case, the chances of getting blood culture is nearly 90% in the first week. And in the second week, it comes down to 70%. So 1:5 is very, very important. And that too, because if there is a 10 ml of the 5 ml of blood, then you need to have only 20 ml of the broth. So it is not that you take 12 ml of the blood and 20 ml of broth. So 1:5 is very important because it is a better yield.
That's so.
Sir, if you give more blood, it doesn't yield because their blood also have inhibitors. So it has to be in correct dilution. So you have to give something where the yield is more and the inhibitor concentration is also less. So 1:5 dilution.
Then you said about 1%, 1% of the blood volume.
Blood volume.
No, that is the 1% of the blood volume. So if the child is 8 kg, 10 kg, we have got the 80 ml of the blood. So that is 1% of blood volume.
True. So that people should be, our friends should be very sure about to collecting adequate sample of blood as well as getting it in the proper dilution into the culture medium.
So
okay, Bala, please.
Excess of blood is also detrimental.
Yes, we got it. Even that is harmful. So that can inhibit the growth. Correctly pointed out by Dr. KHEYA. Bala, please. I'm sorry I interrupted. Bala.
Okay. So we had a good panel discussion, well moderated by Abhay Shah sir. Everybody knows him because about the 98.7 FM TOT. I had attended last.
Thank you.
Along with and I think sir was there for clinical clues also.
Yeah.
So thank you on the behalf of IAP Kerala. I thank Abhay Shah sir for moderating this session, and also I've been fortunate to talk with Ranganath sir today morning. But unfortunately, I couldn't connect KHEYA ma'am and Raju sir and Agnesh sir. So I thank on behalf of IAP Kerala State all the 4 experts: Raju Khadke sir, Agnesh Papat sir, Ranganath sir, and KHEYA ma'am for giving your valuable time for monsoon vibe of IAP Kerala. Also, I thank our moderator Ramesh sir for his. He has been doing all the work. I am just IAP Kerala office bearers just hosting the program only, but he is doing all the program. And next Thursday, we'll be having the Mansoor Raibon DIP platform. We'll be having 2 topics on neonatal sepsis by Dr. Rajesh Kumar from Ranchi, and on allergic diseases, allergic case-based approach on allergic diseases by Dr. Arif Ahmad from Hyderabad. So I thank also my president, Narayan sir, for being with us, and all the delegates from Kerala as well as outside Kerala, especially my friend Sham Tarde from Aurangabad for attending this program. And also thank Ranjit for being the host. Thank you all. Good night. Have a great evening. Thank you.
Thank you.
Thank you all, sir. And
Thank
thanks,
you,
my
Dr.
dear friends.
Dr. Ramesh
especially